I'm Kelly Issokson. I'm the Clinical Nutrition Coordinator of the IBD Institute at Cedars Sinai. And you just heard a wonderful presentation from my colleague Jen Smith about management of nutrition in the PEDS patient. And so I'm going to talk about managing the adult patient. So the next slide is my disclosures, and then the next slide you'll see the learning objectives, which I just kind of discussed. So we'll move on to the presentation. So first, I just want to emphasize that patients think nutrition is very important in the management of their disease. And so they will often come to their GI provider or their APP for questions about what can I eat, what should I avoid? And so when we look on the provider side, less than half of GI physicians think nutrition is very important, but our APPs and our dietitians recognize the value here. And so this is important because your patients are going to come to you with these questions, so being prepared and equipped to answer them is essential. And the other thing I wanted to highlight here is that while our providers are screening our patients for malnutrition, they're not using validated tools. So there could be patients slipping through the cracks that we're missing that we need to really, intervene and provide nutrition support for. So on to the next slide. Okay, this is my older slide deck, but that's okay. So again, patients view nutrition as very important in managing their disease, and many of them are modifying their diet without the assistance of a dietitian or physician. Next slide. All right, so diet matters, and why it matters is because it can affect patients in many ways. It can affect their symptoms, their disease outcomes, their response to their medications. Patients on specific diet therapies can have a kind of a synergistic effect and have a better response to their medications. They can have improved surgical outcomes if we implement interventions to help optimize them and help them recover. They can have decreased risk for chronic disease, such as diabetes, heart disease, and cancer, and an improved quality of life. So a lot of our patients, although they view nutrition as very important, there is a significant fear that many can experience when it comes to food. And so oftentimes in my practice, I see patients who have a decreased food-related quality of life or a relationship with food that is broken. And in some respects, this food fear and aversion is a natural response. If you have ever experienced food poisoning, by having raw or undercooked food or food that wasn't prepared correctly, you are naturally not going to want to eat that certain food that you associate that illness with. Likewise, if there are foods that are constantly triggering symptoms, that can lead you to avoid that food, such as lactose intolerance. Additionally, our medical providers often recommend that our patients go on a low fiber diet if they have active disease or stricturing disease, or modify their diet around surgery if the patient's going through surgery. And then patients will self-modify their diet to manage their IBD. Next slide. All right, this systematic review, I wanted to share this because it really highlights how this food aversion or food avoidance is impacting our patients on a daily basis. And what the researchers of the systematic review showed was that our patients have an inadequate intake of calories, fiber, and micronutrients such as folate and calcium. And then when they looked at specific food groups of patients and what they were eating, they weren't eating enough from breads and cereals food group, legumes, fruits and vegetables, and dairy. And so compared to healthy individuals, our IBD patients are eating less of these foods that are associated with better disease outcomes. And so that's where, we step in. Our role is to help them understand how to get that balanced diet in while not exacerbating symptoms. And I do have my slideshow up, so I'm just going to share my screen so that I can share the most recent version here. I think this is it. Yes. Okay. You can see it, everything okay?
It's still loading right now. Yep, now I see the malnutrition slide. Great, thank you.
Okay, great. Thanks so much, Kate, for helping. So malnutrition, I just wanted to kind of switch gears and talk about this because it affects a lot of our patients. Specifically, speaking about the definition of malnutrition, it is an acute or chronic state of under or overnutrition with or without inflammation that leads to a change in our patient's body composition and diminished function. So that's the definition from the Academy, the American Society of Parenteral and Enteral Nutrition. And when we look at malnutrition and IBD, there are many factors that can contribute to malnutrition, such as maldigestion, malabsorption, enteric losses, surgery, their increased needs from their disease activity, effects of medical therapy, and inadequate intake. And I think of all of these factors that contribute to malnutrition, inadequate intake contributes the most here. And so this can lead to, you'll see on the right-hand side of the screen, complications such as growth failure in pediatrics, reduced response to their medications, increased risk for non-elective surgery, infection, and sepsis, longer hospital lengths of stay, up to 3 times longer, perioperative complications, increased mortality, and then, of course, increased costs for care. And so when a lot of times on teaching rounds, when I ask fellows or residents or trainees, how do we identify malnutrition in patients, albumin and pre-albumin are often the first things that people talk about. But that has been debunked. And we know that albumin is more influenced by inflammation and doesn't really tell us about the nutrition status of patients. So because malnutrition is so common in our inpatients and our ambulatory patients, the AGA and ESPEN, the European Society for Clinical Nutrition and Metabolism, recommend that all patients are screened at diagnosis and on a regular basis. And so how do we screen? I recommend you use a validated screening tool, and this is consistent with the Crohn's and Colitis Foundation's nutrition care pathway. They recommend using the Malnutrition Universal Screening Tool, and that only asks 3 questions, one about BMI, one about recent unintentional weight loss, and one about the acute disease effect of on oral intake for your patient. And if your patient answers yes to any of these red flags, then you'll want to refer them to a registered dietitian for a comprehensive nutrition assessment and plan. And then in addition to that, ESPEN guidelines recommend that all patients with IBD receive counseling from a registered dietitian. So is there a perfect diet for people with IBD? You heard a little bit about evidence-based diets from Jen, and we do know that diet can affect the microbiota, the metabolome, immune response, and the mucus layer of the gut. And there is evidence suggesting that a westernized lifestyle, such as a diet high in red meat, fat, food additives, and low in fiber increases the risk for IBD onset. Ultimately, there are diets that can help our patients, but diet should be individualized. And we want to look at what is the patient's nutrition status, what type of IBD do they have active disease, or is it quiescent? Are they preparing for or recovering from surgery? What does their socioeconomic status look like? What about their cultural background and their relationship with food? I really want to emphasize here that diet restrictions and defined diets are not for everyone. Sometimes patients just need support in helping to understand what can I eat throughout the day. And so that's where dietitians and the team collaborative approach helps to, patient shared decision making, ultimately all helps us to come to what is best for that patient. I think the most reasonable nutrition approach is to recommend a Mediterranean or a plant-forward diet. This is consistent with the AGA clinical practice update that was recently published. There is a lack of evidence to recommend that patients follow a low-fiber diet. We know that fiber is a substrate for short-chain fatty acids, and recent data suggests that patients not only feel better when they incorporate fiber into their diet, but they have better disease outcomes. If your patient has strictures or obstructive symptoms, you can recommend a diet with altered texture, and I'll talk a little bit about that in the next few slides. And nutritious fluids can also be used in those situations. But a Mediterranean diet encourages lots of plants, fresh fruits and vegetables, monounsaturated fats, complex carbohydrates, and lean proteins, and discourages ultra-processed foods, added sugars, and salt. So I typically don't recommend that my patients limit fiber in a flare. What I talk about with my patients is more about fiber type and fiber texture. So first, fiber type, there are many types of fiber you've probably heard of and are familiar with: insoluble and soluble fiber. So that's one type of fiber, but also fiber can have an effect on viscosity and fermentability within the gut. So if your patients are experiencing diarrhea, they might want to incorporate more soluble fiber, fibers that dissolve in water, and viscous fibers, fibers that help to thicken that stool output and slow motility. So examples would be beans, oats, peas, avocado, sweet potato, pears, turnips, and psyllium fiber. Sometimes people experience more constipation with flares, like our patients with proctitis or colonic disease. And so they may benefit from more insoluble fiber, which doesn't dissolve in water, adds bulk to the stool, and helps with gut peristalsis. So some examples of that would be whole wheat fiber, wheat bran, cauliflower, and green beans. A lot of our patients experience gas and bloating, so I talk about fermentable fibers with them. Foods like beans and inulin, wheat dextrin, and oligosaccharides can contribute to gas and bloating. So I look at ways to modify the diet to help with those symptoms. And then in our patients with kind of like alternating diarrhea or constipation or fecal incontinence, soluble, non-fermentable viscous fibers might be beneficial, such as psyllium fiber. And this is an example of what I was referring to when I talked about a diet of altered texture. So this has recommendations for what to eat if you're flaring on the left-hand side, or if you have stricturing disease or obstructive symptoms. Those are going to be foods that are whole, but more processed and broken down. So examples would be creamy nut and seed butters instead of whole nuts and seeds, fruit and vegetable purees, tofu, cream of wheat and rice, mashed potatoes, or liquid, nutritious liquids. And then as your patient starts to feel better and they're transitioning out of a flare, they can have more of the fork, tender, and soft foods. And then once they're in remission, they can transition to those whole foods that are rich in those soluble and insoluble fibers and larger in particle size and texture. So what are some general recommendations for nutrition during a flare? Again, modify the fiber type and texture, not necessarily a low fiber diet. Smaller, more frequent meals can help your patients to nourish. Gutfriendlyrecipes.org is a great website from the Crohn's and Colitis Foundation where patients can go and filter for flare-friendly recipes. And those have all been tested and vetted by, a dietitian, and they're a really great resource for patients. There's even an option for stricture-friendly filter for patients who are experiencing strictures or obstructive symptoms. I encourage high-calorie, high-protein diet because their needs are really high during a flare. limit lactose, spicy foods, fatty foods, caffeine, and alcohol. That's kind of like, those are some of the common triggers. Some patients tolerate lactose fine, some are fine with spicy foods. It's really more individualized there. And then sometimes, they don't always have to keep a food and symptom log. Sometimes that can be really anxiety provoking, but helping patients to identify safe foods can help them to navigate those flare episodes while still being able to nourish. Foods like yogurt or the soups or smoothies can be safe foods for a lot of my patients. And I would recommend considering oral nutrition supplements if your patient's losing weight or really struggling with eating, because these are a really great way to supplement the diet during these periods of flares. And this is consistent with the Aspen Guideline on Clinical Nutrition, IBD, using oral nutrition supplements, ONS, as the first step when medical nutrition is indicated in IBD as supportive therapy in addition to normal food. And I just have some examples of how we use ONS in different ways in IBD to prevent and treat malnutrition and sarcopenia, to induce remission, which you've heard about, as combination therapy with medication, as maintenance of disease remission, and then to help with surgical preparation and recovery. So I'm just going to go into a little bit of this, maybe a review, but I just wanted to talk about the diet therapies to help decrease inflammation and maintain remission. I'm going to start with established evidence first, which is mostly looking at the formula-based diets, which you've already heard about. So exclusive enteral nutrition can help decrease inflammatory cytokines in Crohn's disease, promotes fistula closure, and can serve as a bridge to safer elective surgery. And partial enteral nutrition can help reduce relapse rates as well as increase the odds of achieving remission. And so exclusive enteral nutrition is getting all of your nutrition from formula for a period of 6 to 8 weeks, whereas partial enteral nutrition is getting about half of what you need from formula and the other half from a healthy, balanced diet. And I have examples on the right-hand side of this screen of some of the formulas that I typically use, with the exception of Modulin, which is no longer available on the US market. So this is kind of a review of what I just discussed. We don't know why EEN works, but we hypothesize that it downregulates pro-inflammatory cytokines and alters bacteria to decrease intestinal inflammation and improve symptoms. And it's slightly more effective in pediatrics, slightly less effective in adults with Crohn's disease when compared to steroid therapy, according to a Cochrane meta-analysis. But we don't have a lot. We have more data in the pediatric world than in the adult world. And in the adult world, adherence is the primary issue. This is a really great study that I like to reference because it really shows the impact of exclusive enteral nutrition, especially in our complicated Crohn's disease patients, and how it can improve outcomes for them. And this cohort was about 51 adults who were on EEN for 4 weeks before surgery, and 25% improved and no longer required surgery. It was well tolerated. 94% of patients tolerated at least 4 weeks of EEN, and the authors concluded that EEN downstages the need for urgent surgery. Patients on EEN had lower rates of anastomotic leak, lower rates of high stoma output, and shorter times in the OR. So it's a really great adjunctive therapy that we discuss with our patients who are preparing for surgery. And so here's some of my practical advice for the clinician. There are differing indications and durations of therapy based on what you're using EEN for. And then some tips for promoting adherence. Palatability can be an issue, taste fatigue. And so talking to patients about ways to make the formulas more exciting or more palatable is important. Sometimes on hot days, patients will freeze the formula into ice pops, or if they're on partial enteral nutrition, they'll blend the formula with some food like a banana or chocolate. But there are different ways that we can help to increase adherence and tolerance with our patients. It's not covered by insurance, so a lot of our patients have to pay out of pocket. And so that can be a barrier to access, but there are patient assistance programs available for those who qualify as well. And so now I just want to kind of shift to whole foods-based diets. You've heard about a lot of these diets, but I just wanted to speak a little bit more to like how it affects our adult population. So Crohn's disease exclusion diet, as you know, is a partial formula diet. It was originally studied with the Modulin formula, but because that's no longer available on the US market, I use any balanced nutrition formula for my patients who choose to follow this diet. It's done in 3 phases and has been shown to be better tolerated than exclusive enteral nutrition and equally effective at inducing steroid-free remission at 6 weeks. And then a recent randomized controlled trial suggested the formula component may not be needed. Patients in a small study had similar outcomes. So for my patients who are really against formula, which we have some who don't want to, incorporate the formula, I can still, support them through the diet and just monitor them and use those objective markers of inflammation to assess whether or not the diet therapy is effective. Modulife.us is a website that I would highly recommend you go and learn more about the diet, and you can even become a certified provider so that you just feel more comfortable talking about this diet and can help your patients through it. These are the potential mechanistic implications for the Crohn's disease exclusion diet. So on the left, you'll see like a Crohn's disease exposure to a Western diet has been shown to decrease gut diversity, which increases dysbiosis and alteration in the gut barrier function, increasing intestinal permeability and increasing inflammation ultimately. And on the right, the Crohn's disease exclusion diet has been shown to decrease pathobionts, increase firmicutes and gut diversity, decreasing intestinal permeability and inflammation. So what's on the menu? There are mandatory foods, allowed foods, and foods to avoid. The mandatory foods are bananas, apples, chicken, eggs, potatoes, and the formula. And then the allowed foods will grow. So this is not all inclusive. It's more restrictive in the first phase and gets less restrictive in the second phase, and then even less restrictive in the third phase. And this, I just grabbed some pictures of the Crohn's disease exclusion diet from the Gut Friendly Recipes website. So there's really great recipes that patients can use in this diet. It can be really fun to do for our patients. So who's it for? The strongest evidence for CDED is for those with active, mild to moderate, allocolonic, uncomplicated pediatric luminal Crohn's disease. And there is evidence suggesting it's effective for our adults as well. The weakest evidence is in those with severe, extensive, stricturing, penetrating Crohn's disease. But real world evidence suggests it can be useful as adjunctive, rescue, or bridge therapy. And it's not recommended for those with disordered eating, eating disorders, or those lacking motivation or access to follow this diet. These are some great resources. Modulife is available in 10 different languages. They have an app to help patients follow the diet, and it includes info on local foods and customs. MyModulife.com has recipes, diet information, and a dietitian directory of all of those who are certified providers. The Crohn's and Colitis Foundation has a diet information, and then NT4IBD is also a resource that has information on this diet as well. And then just shifting to the specific carbohydrate diet, I think of all the diets, this is probably the most restrictive and like the hardest for our patients to implement. But once our patients get the hang of it, a lot of my patients have really good positive experiences with this diet. It does require a lot of preparation, a lot of resources. You know, if you're not able to cook your meals, if you don't have access to a lot of fresh foods, if you have access to more convenience foods, it makes it a lot harder to follow this diet because it eliminates pretty much essentially all processed foods. So it's a grain-free, sugar-free diet, as Jen explained. And a big part of this diet is homemade yogurt, which can feel overwhelming to patients, but it's very easy to do and very delicious. I've done it myself. So again, this is an option for our patients. And I think, patients appreciate having these options so that they can choose which one is best for them. But it's certainly a diet that requires a lot more support and resources. And here are some recipes, pictures of recipes from the Gut Friendly Recipes website. On a grain-free diet, you can't have bread and you can't have pasta. And so being creative and making recipes using almond flour or coconut flour to make things like breads or pancakes is a great way to like add diversity and variety to the patient's diet. So who's it for? The strongest evidence is for those with active, mild to moderate, uncomplicated luminal Crohn's disease and ulcerative colitis. So here's a diet for our UC patients, which we don't really have a lot of data for. So this is for children and adults. The weakest evidence is in those with severe, extensive, structuring, and penetrating IBD, but real-world evidence suggests it can be used as adjunctive therapy here. And then it's not recommended again for those with disordered eating, eating disorders, and those lacking motivation or access. So here's some great resources. Nimble.org is a website developed by Dr. Susskind and colleagues from Seattle Children's Hospital. BreakingTheVicious Cycle.info is a website with a lot of information about the diet. That's the book I recommend my patients read if they want to start this diet. There are some companies that make SCD-friendly packaged foods and supplements and ice cream, Fronen, that I like to share with my patients. And the Crohn's and Colitis Foundation has great information, as well as indeed4ibd.org. And then Jen talked a little bit about this DINE-CD study. So it was comparing the specific carbohydrate diet to the Mediterranean diet. And here's their primary outcome, which was at 6 weeks. They didn't really see any significant difference in symptomatic remission or fecal calprotectin response or CRP response between the two diets. So the conclusion was SCD is not superior to the Mediterranean diet. And so it's reasonable to recommend something like the Mediterranean diet for helping with symptomatic remission and fecal calprotectin response in your patients who want a diet therapy but aren't able to, for whatever reason, commit fully to the specific carbohydrate diet. So Mediterranean style diet, again, rich in olive oil, fruits and vegetables, cereals, nuts, seeds, and legumes. I have a Mediterranean table on the right-hand side of this screen, which includes exercise and weight control and plant-based diets at the bottom of the pyramid, and then less of those red meats and added sugars at the top of the pyramid. And this diet has been suggested to help not only those with Crohn's disease, but also those with ulcerative colitis, especially those who have had a pouch surgery, which is even less well studied in terms of like what we know about diet and how it impacts IBD. So it's great to have this option for patients to discuss to help them navigate, their post-surgery diet and help with controlling symptoms and disease activity. And I just wanted to share this recent publication in gastroenterology from Dr. Dotan and Dr. Godney, talking about the mechanism and mechanistic implications of the Mediterranean diet in our patients with newly diagnosed Crohn's disease. They followed 271 patients with Crohn's disease over 2 years. And what they found is those who adhered to a Mediterranean diet more closely had greater non-complicated Crohn's disease course, less or lower CDAI scores, lower CRP and fecal calprotectin, and a more beneficial microbial profile, intestinal microbial profile. So this suggests that this diet is beneficial and really helps and kind of has a more of a long-term effect and can help our patients with having a less severe course of disease over time. And I just wanted to end with talking a little bit about nutrition and surgical care. This is something that is really important to me and something that I've been researching at Cedars, which is how does nutrition impact the care of our patients who are undergoing surgery. 47% of our Crohn's disease patients and 16% of people with UC undergo at least one surgery during their lifetime. So this is important to look at how we can optimize their outcomes or improve their outcomes. And then Patients who need surgery often present malnourished or unwell. They have a prolonged disease course. They can have fistulas, strictures, disease complications, which can increase their surgical risk for complications. Um, so, EROS, which is Enhanced Recovery After Surgery, is multiple studies showed that it's associated with lower morbidity and shorter hospital lengths of stay for our elective colorectal surgical patients. And research is coming out showing that it's beneficial for our IBD patients as well. At Cedars, we're seeing that our IBD prehab program is decreasing hospital length of stay, and that saves lots of dollars on the inpatient side and helps our patients get back to their lives a lot quicker. I think one of the most important aspects of helping our patients prepare for and recover from surgery is minimizing the NPO, the time that they're not allowed to eat. Patients who receive pre-op nutrition support have been shown to have better outcomes, and giving them something as simple as a nutrition supplement shake 7 to 10 days before surgery can help reduce infection and leaks. So that's really impressive. You drink this shake a couple times a day for a week to 10 days before your surgery, and you are more likely to have less infection and less leaks. Patients also have less post-op complications if they're on nutrition support before surgery. And then carbohydrate loading is just giving a patient a high dose of carbohydrates the night before in the morning of surgery. It's kind of a way, if you compare surgery to a metabolic stressful event like a marathon, our marathoners will prepare for that run the night before by eating a big plate of pasta. And so the way we do this in our surgical patients is we have them drink a clear liquid carbohydrate-rich beverage, which can help to load their muscle and liver up with glycogen stores so that they go into surgery in a fed state instead of a fasted state. And this has been shown to have multiple benefits on the perioperative and postoperative side. So patients have less post-op nausea vomiting, they have a better retention of their muscle stores, better cardiac function, and they can have improved glycemic response after surgery. So it's really beneficial and a super simple intervention that we can recommend. And this is consistent with the ASCARS and the SAGES guidelines for enhancing surgical recovery, which I have on the screen here. Preoperatively, screen for malnutrition and anemia, educate on diet based on what surgery they're having and how that's going to affect their nutrition or absorption, talk about carbohydrate loading and how patients can do that, and then have patients drink the clear liquids up to 2 hours before surgery instead of fasting for the whole day before surgery or the night before. Sorry that this keeps auto advancing. And then post-operatively, make sure that the patients are mobilizing early and get them to eat a regular diet as soon as possible. Most patients aren't able to nourish adequately after surgery. Studies suggest that they're only able to eat about 1,200 calories on average. And so adding an oral nutrition supplement 2 times a day, 3 times a day can help them get closer to their calorie goals so that they can recover better and get out of the hospital sooner. So that's what I recommend, and that's what we do at Cedars Sinai. We screen for malnutrition and anemia. We talk about high calorie and protein needs before and after surgery using oral nutrition supplements, nutrition support if needed, that exclusive enteral nutrition or tube feeding or TPN in patients who are malnourished and unable to eat enough or utilize their GI tract. And then we also talk about immunonutrition and carbohydrate loading. Immunonutrition I haven't really discussed during this presentation, but that's essentially a nutrition supplement that's enhanced or fortified with omega-3 fatty acids, arginine, and glutamine, which can help to mitigate that inflammatory or catabolic response that patients experience during surgery and help them recover faster. And yes, try to minimize periods of NPO as much as possible. Here's our perioperative nutrition protocol. Our prehab clinic is run by, it's It's run by a nurse practitioner and a dietitian. So we do combined visits with the patients where we talk about how to optimize their medical therapy. We order labs, we correct nutrition deficiencies. Patients also see a social worker during their visits and a physical therapist to address mental health needs and talk about exercises to improve mobility and strength. And then I just included a little bit more detail about what I do as part of that combined visit. I also meet with the patient separately from the nurse practitioner. We have virtual visits and multiple visits throughout their surgical journey. Patients have a lot of questions about like, how do I best prepare for this? What do I need to eat? What can I eat after surgery? And so just helping guide them through that and support them through that can really reduce anxiety and help them feel more supported and help them recover a lot faster. So it's really been the highlight of my career to be part of this prehab clinic. And I just wanted to end with my suggestion for an IBD nutrition screening and assessment algorithm. So it starts with screening. You can use the MUST screen, the Malnutrition Universal Screening Tool, or the MST, which is a malnutrition screening tool. Both are simple and validated. If this patient screens negative, rescreen them periodically or with disease flares. Make sure you're checking annual labs like vitamin D, ferritin, iron saturation, hemoglobin, and B6. Those are the labs that our patients are most at risk for being deficient in. Check bone density and refer to a dietitian as requested. If the patient screens positive, refer them to a dietitian for nutrition assessment, where we can understand what the driver is of that malnutrition, if it exists, and we can implement interventions to help correct that. And then we'll follow up every 1 to 4 weeks until that patient's stable. And then, of course, correct micronutrient deficiencies and rescreen within 1 to 3 months after that repletion. So in summary, evidence-based diet therapies exist for our adult IBD patients, and it's important that we talk to patients about what those options are. Malnutrition is common, and it's important that we intervene early for best outcomes. And our surgical patients, consider applying nutrition optimization strategies, as they can have significant impacts on their post-op recovery. And then as an action item, ask your representative to sponsor the Medical Nutrition Therapy and Medical Nutrition Equity Acts, so that these barriers to nutrition care, meeting with a dietitian, having access to formula covered by their insurance provider, so that these barriers are removed for our patients, so that they have better access to quality care and ultimately better quality of life. Here are some resources. And then this is my contact information. So you'll have a copy of my slide deck